All right. Well, it's my great pleasure to introduce my co-moderator, Rob Hawes, who is, he's the expert's mentor, and he's a guy that has influenced the careers and the practices of I can attest everybody that's on the brochure, and I'm sure so many of you who are attending. And so, Rob, thank you so much for all you've done for so many in our profession, as well as for our patients, and for being a great ambassador of particularly endoscopic ultrasound around the globe. And so, please bring us up to date. Thank you.
Well, thank you, my friend. It really is a great pleasure to be with all of you. And again, I'll echo what everybody else has said, and thanks to Haru for really a huge effort to put this course together. And I do dearly wait for the time when we can be together physically. But again, it's great to be with all of you. So I was assigned to talk about EUS for pancreatic solid and cystic lesions. So I think without further ado, I'll have you go ahead and run the tape, and then we'll take some questions afterwards. Well, good morning. It's a pleasure for me to join you, and I'm very grateful to be invited to be a part of Tokyo Live 2020. My thanks to Haru and the organizing committee for having me. The topic that I'll be discussing is EUS for pancreatic solid and cystic lesions. These are my disclosures. The issues that I'll be discussing with regards to pancreatic masses and EUS is detection, staging, tissue acquisition, and palliation. In terms of detection, EUS has a role for small lesions, less than 2 centimeters, for the evaluation of IPMN, and maybe it has a role in screening and surveillance in familial pancreatic cancer. In terms of staging, to be honest, EUS has largely yielded to multi-detector CT scan, perhaps with improved transducers or processors or contrast agents. We will regain some ground that we've lost to CT. In terms of tissue acquisition, we have largely gone now to the so-called FNB needles. You can see the 4 types of FNB needles shown on this slide. The 2 on the right are the predominant ones, the Shark Core from Medtronic and the Acquire from Boston Scientific. We looked at the tissue acquisition characteristics of FNB needles and the FNA needle. And you will see here in this slide that from a diagnostic adequacy standpoint, there was no difference. But the clear difference, however, is in the amount of tissue that is acquired. And you can see here that the diagnostic adequacy in terms of the cell block was significantly better for the FNB needle when compared to the FNA needle. We looked at this a little bit more carefully and tried to quantitate the quality and the amount of tissue that we got with the FNB needle compared to the FNA needle. And you can see here on the right that there was a statistically significant difference in all the parameters that we measured in terms of volume of tissue, desmoplastic fibrosis, etc. And particularly in terms of suitable for immunohistochemistry studies, there was a significant difference. So really going forward, the FNB needles are the needles of choice for EUS guided tissue acquisition. If you look at palliation, we can now do biliary drainage under EUS guidance. We can do pain management with celiac plexus neurolysis. Both of those are effective. Whether or not biliary drainage will be taken over by EUS versus ERCP is yet to be determined. In terms of treatment, however, unfortunately, we have not found a suitable material to inject into pancreatic cancers that makes any difference. So we have a long way to go in terms of treatment. I want to move on now to EUS in pancreatic cystic lesions. This breaks down for me in terms of imaging in this way. I think that CT is the predominant form of detection. Most of these patients come in and undergo a CT for one reason or another, and then a cyst is picked up. In terms of surveillance, I think that MRI is now considered the mechanism of choice in surveillance. So I see the role of EUS as most effective in detecting malignancy within these cysts. If you look at the EUS techniques to detect malignancy, we have a number of them. First is EUS and cyst fluid analysis. This can include imaging, cyst fluid cytology, cyst fluid tumor markers, cyst fluid genetics, and duodenal juice. And of these, imaging is not particularly effective, although using contrast agents, you can detect mural nodules. Cyst fluid cytology is rarely yields sufficient material unless there is a solid component to the cyst. Cyst fluid markers are being studied, but not yet ready for prime time. Cyst fluid genetics is the same. And really duodenal juice, Japanese have sort of pioneered this, but again, there are problems with it. In terms of new methods, there is brush cytology, mini biopsy forceps, confocal laser endomicroscopy, and cystoscopy. And of these, none of them have proven very reliable. But I think in terms of my view, at least, the mini forceps biopsies perhaps hold the greatest chance of impacting our detection of malignancy. The reason that this is critically important is you look here at the 5-year survival when you do surgery on these lesions when they're still benign versus when there's already malignancy. And you can see here that the 5-year survival, if benign lesions are detected, is almost 100% or is 100%, whereas it drops down to about 60% 5-year survival if you're operating on these patients after malignancy has already occurred. So I think this is an issue and a problem. When you look at the accuracy of the Fukuoka guidelines to predict advanced lesions, here's 194 patients using the Fukuoka guidelines. And you can see here that we're far from perfect. The sensitivity was 56%, the specificity 73%. The negative predictive value was fairly high at 88%, but the positive predictive value was only 32%. So I think there is certainly some great room for improvement in terms of EUS and ancillary procedures as part of EUS to make this better. So my conclusion are that all guidelines will be limited by our inability to characterize cysts. More must be known about the natural history of cysts to be able to apply guidelines, and choose your poison. You can go to more surgery to avoid missing curable lesions, or you can do less surgery and accept that some chances for cure will be missed. So with that, I'll close. I want to thank you for the opportunity to be with you, and I hope that I can join you on a Zoom call to answer any questions. Thank you very much.
So short and sweet, guys. I was intimidated a little bit. I first submitted my Zoom, and I think it was 30 minutes long, and I got this very challenging response back from Misaki that I needed to cut that short. So maybe I cut it a little bit too short, but those are my thoughts on EUS and solid and cystic lesions. If there are any questions, I'll be happy to take them.
Hey, Rob, so thanks for a concise and yet comprehensive presentation. So your approach to pancreatic cystic lesions, so which ones do you choose to do fine needle aspiration of? Can you talk a little bit about your very specific technique, and how do you handle your specimens? What do you send it for? And then we can talk about how you use that information to guide management.
Yeah, so I suspect our practice is like your all's practice as well. We started out aspirating almost all of these cysts, and now we aspirate almost none of them. If I think it's an IPMN, I'm almost never aspirate a true side branch IPMN. I will biopsy a main duct IPMN if the duct wall is thickened. But in terms of cyst aspiration, it's really pretty much the unilocular cysts that may be serous cystadenomas, and always ones that are at least a couple centimeters in size, so we get enough material. And I must admit that we're not very sophisticated. We send ours for cytology and for CEA. Appreciating that a lot of the CEA levels fall outside the bell-shaped curve, so to speak. So ones that look mucinous, maybe even are sort of thick, will come up with a low CEA, and vice versa as well. So we don't aspirate very many anymore, Greg. And in terms of biopsy, only those that have mural nodules or some sort of actual mass.
So you're really using, in terms of the morphologic criteria that would prompt you to do a needle aspiration, you're throwing out size? So if it's a cyst greater than, say, 2.5 centimeters, without a mural nodule, without mass, you're not going to even aspirate that.
So yeah, I mean, a unilocular mass with no mural nodules, it's less than
not mass, a unilocular cyst.
A unilocular cyst, yeah. Again, if I really think that in the differential is a serous cystadenoma, then I will aspirate it. But if I'm pretty well convinced that it's mucinous, I tend not to, just because the CEA tends to screw me up more than it really helps me. I'm going to survey those people almost irregardless, unless it's a classic serous cystadenoma.
Okay.
Sorry, Rob, I wanted you to give me your take on the Moray forceps, or, a 19 gauge needle pushed into the pancreas, in terms of, are we using it too much, too little, the risk of pancreatitis? I'd love to hear your take on that.
Yeah, so again, we don't use it a lot, and there is a very real risk. I mean, a 19 gauge needle in and doing the forceps and making several passes and so forth, I think there is a risk. My feeling, however, is that the data, at least with IPMN, based upon the actual histology being variable between gastric and intestinal and pancreatic, et cetera, and that influence that it has on prognosis, I think is the most valuable information that I see right now. So, and it's the forceps, at least in my mind, that have the greatest chance of getting that kind of information. But that being said, it's not perfect, and there are some risks to it. So it's always this risk-benefit ratio. Is it going to really change my management depending upon what the results are? And I don't have a definitive sort of answer to that.
Right. Good perspective.
It's become epidemic.
Yes.
13% of people that undergo cross-sectional imaging will have a pancreatic cystic lesion. For patients in their 70s or older, it's up to 30%. And while there's been an 8% per year increase in the prevalence of pancreatic cystic lesions, there's been no associated increase in pancreatic cancer or pancreatic cancer mortality. Not that it's insubstantial, but the increased detection of cysts has not correlated with increase. And I think, as you point out, we've come to recognize that most of these are indolent, and it's time for us to begin to back away. What we're really sorely needing are better tools, be they morphologic or immunohistochemical, that are going to be able to help us better define early on, which are the ones that we can ignore completely and which are the ones that are more substantial. Robert, do you host a surveillance program for patients who have a family history of pancreatic cancer or BRCA2 gene? And does that influence your approach?
So we don't have a program that we initiated ourselves. We've partnered with Hopkins, sort of dovetailed on to the southern migration of patients that come from the north and come to the south. So we have partnered some with Hopkins. We don't have a standalone program, at least at our place, for that. No. And I agree with you 100%, Greg. I mean, I live in a state of elderly patients, and it's overwhelming how many patients we see with these cysts. And I agree with you. For those that we survey, particularly in whom we suspect side branch IPMN, the overwhelming majority of them are indolent. They don't change much, and it's we really need a lot more information on the natural history, and it would be great if we had the information where we could just shelve a large proportion of these people, knowing that they're not going to go forward with progression of disease.
Yeah.
When you touch on differentiating those 4 types in the IPMN, it's very interesting that UCI data said once you get those types with the biopsy, it's about 80% right with the surgical pathology. So that correlation is really intriguing, that you're putting a 19 gauge needle to take a biopsy. The patient selection is again, it becomes a key. My question to you is nowadays, keep coming back on the glucose level. Do you think there's any additional role adding a glucose level for the cyst fluid?
So we've not done that, Norio. That's not become a routine part. I think there's a lot of different things that will come out as being important in the future. Whether glucose will be one of them or not, I don't know yet.
Fair enough.
I assure you that the answer will be much more expensive than a cyst fluid glucose level.
Next gen sequencing.
Yes.
All right.
All right, guys.
All right.
I think, Greg, we probably need to close this up.
Yeah.
Thanks.
So
thanks, Bob.
On behalf of the entire United States, we would like to thank Haru and his co-organizers, all of Japanese gastroenterology, for inviting our participation in this very excellent course. And we wish you all, continued safety and blessed holidays. And we look forward to hopefully the very near future where we can all be together again and enjoy each other's company and each other's opportunities for learning and education. So peace.
Thank you.